You might smell a rat when you've got a painful cat that's straining to urinate, and you think, aha, urethral obstruction, and then you feel an empty bladder.
Okay.
And then the plot thickens.
Hi, I'm Hubert.
This is Gerardo.
Hi, I'm Dave Collins. I'm a small animal medicine specialist who works in the north of Sydney.
And you are listening to the Vet Vault Clinical Podcast.
Hello Vet Vaulters, and welcome back to another one of our clinical episodes. I decided to share this one with the wider world because of a case we dealt with just this morning. We had a cat in hospital who'd gone into what was initially thought to be acute renal failure, but that turned out to be a ureteral obstruction. That's ureteral, not urethral. And seeing this case reminded me of how dangerous this disease is, but also how easily it can be missed with devastating consequences. This made me think that I really should share this episode we recorded with Dr. Dave Collins, our resident medicine specialist, a couple of weeks ago. Because up until I did this interview with Dave, ureteral obstructions just wasn't really on my radar for acute kidney disease. But it's apparently more common than we think, probably because we've been missing them. If this is a surprise to you, then I recommend you plug in and let Dave tell you everything you need to know about ureteral obstructions, from spotting them, diagnosing them, and all the way to how they can be fixed. And if you enjoy this episode and you feel like you could use more of these updates to sharpen your skills and become the smartest vet in your clinic, then you should check out our clinical podcast series if you haven't already. It's 3 20 to 30 minute episodes every week, backed up by summarized show notes, so you can refer back to all the goodness at a later stage when you need to refresh your memory. Our goal with these clinical episodes is to give you a handful of practical takeaways with every episode that you can go and apply in your workplace straight away, in an easy to digest, hopefully enjoyable medium that you can consume while you get on with your life. I had a lovely email from a member this week to thank us for the clinical podcasts, and she told us that it's way more useful than any other CPD that she's ever tried. And that's a quote, which of course made my day. Go and try it for yourself at thevetvault.com. Just click on the clinical button on the top right hand of our homepage. Okay, back to Dave and ureteral obstructions.
Hi Dave, welcome back.
Hey, Hubert, great to be back.
Now we've got an interesting topic today. When I asked you what should we talk about, you kind of blindsided me with this one. Purely because I had no idea that it was a thing. But that makes me wonder if I'm missing them. You said let's talk about ureteral obstructions, but not urethra. I even read it wrong. So obstructions of the ureter.
Yeah.
Is it a thing? Are we missing them? Have I missed them?
Yeah, well, I think it's become, particularly with ultrasound, it's become more and more recognised, and we've worked out that the prevalence is increasing. And I guess also, many years ago when science determined struvites were a big cause of obstructions, and mostly urethral at that point, the diets changed components to minimise magnesium, ammonium and phosphate, the struvite components, and the flip side was a massive increase in calcium oxalate uroliths. So I think veterinary science is just getting on top of what kind of balance of minerals and pH and whatnot is right for minimising stone formation generally. But yeah, the incidence of calcium oxalate has massively increased in the last 20 or 30 years. And most of the big problems we face are in the upper urinary tract, so nephroliths and ureteroliths.
So the foods that say they're just anti-stone or stone preventing, is that false advertising? Or are they...
Oh, no, I think the technology's caught up. The big companies have found the optimum pH and precipitation factor, or whatever they call it, to minimise both oxalate and struvite formation. Okay. But I guess the immediate reaction to struvite urolithiasis was to acidify diets. Mm-hmm. And of course, calcium oxalate loves forming in acidic urine.
Okay, cool. And dogs and cats, or?
Well, yeah, we see it a lot in cats and not so much in dogs. In fact, I've rarely seen ureteral obstructions generally in dogs. When I have, it's usually secondary to transitional cell carcinoma obstructing at the level of the trigone in the bladder. Whereas cats, I think we see a urethral obstruction every few weeks. Some of the big centres see 1 or 2 a week. There hasn't been a lot of Australian data or seasonality done, but I get a feeling that springtime, when things are warming up and cats are getting further behind on their hydration, seems to be a bit of a peak onset for us.
But that's more the fluted syndrome of diseases that causes those, because when that in emergency, that's a regular thing. Certain times of the year we see lots of block cats.
Yeah.
But the lower urinary tract. So are we talking about, does the same sort of stuff affect higher up as well?
Yeah, absolutely. So most common lower urinary tract urethral obstructions is going to be struvite.
Yeah.
And I guess the population I see is going to be pretty biased. You know, a lot of practitioners see urethral obstructions pretty commonly and deal with them, sort them out brilliantly, and we don't get involved. Whereas some of the more occult, generic sick cats, vomiting, lethargic, inappetent, maybe pyrexic, it can be a bit hard to determine. But I think if you boil down to it and do some bloods and imaging, a lot of these, I guess what previously might have been assumed as being acute kidney injury, the main differentials have probably got to be Lilly toxicity, pyelonephritis, for example, various other infections. But I guess with the advent of imaging and recognising the significance of a dilated renal pelvis means that we're diagnosing urethral obstructions a lot more commonly.
So what do they present like? If they're coming through the door?
Yeah, that's a good question. I mean, like any cat, they never give you much help in making a diagnosis with their disease, but they're often quite painful and often vomiting, inappetent, abdominal pain, sometimes pyrexic, and sometimes it's an incidental finding, well, not incidental, but sometimes there's a syndrome called big kidney, little kidney, and there's a few differentials of that, such as cystic kidney disease or even lymphoma, which is probably more often bilateral. However, sometimes we discover these cats have a urethral obstruction when the second kidney's, the kidney or ureter is obstructed, and the first kidney may have been obstructed and shut down a year or years ago. And so that kidney is then shrunken and a chronic kidney or even a dysfunctional kidney. And it's been living on one kidney, which is hypertrophied, and particularly when it's obstructed, it presents as an acute emergency with an enlarged, painful kidney.
So the big kidney, little kidney, there's 2 scenarios. That's either it's a chronic thing and the little kidney's a dead kidney.
Yep.
Or is it also acute when you have an acute obstruction that the big one is an abnormally swollen?
Yeah, well, a bit of both. Yeah, I think they can hypertrophy when they're the solitary kidney, or more acutely secondary to a urethral obstruction.
Okay, so fairly non-specifically sick cat, but
absolutely.
Telltale signs, abdominal pain. Are they always painful? You think they would be?
Most times, not only painful, but angry. And I guess that kind of comes down to breeds. We see a lot of Maine Coons, and there's not a lot of data in Australia about breeds, but some of the breeds that have been mentioned in the US are Maine Coons and Siamese. Of course, we see a lot of domestic Shorthairs, but some of them are going to be painful and just plain angry. It stresses the importance of doing bloods. Sometimes it's a big financial commitment when they're kind of vague, non-specific signs. But if you've got a pretty decent azotemia, I'm talking 300, 400, 500 plus creatinine, then we may be dealing with urethral obstruction. Of course, you've got to be very careful in the history to talk about potential Lilly exposure. Leptospirosis is pretty rare in cats, but I guess you've got to have a chat about their environment and their background, indoor, outdoor cats, for example.
So non-specific cat comes in, painful abdomen, you run bloods, and you go, okay, azotemia, decent azotemia. As you say, mostly I'd certainly immediately think of toxicities or a pyelonephritis. Is there anything there before you put a probe on it that's going to make you think of it, or is the next step just, okay, there's something up with the kidneys, let's go scan it?
Yeah, I guess there may well be, I guess if it's a sort of chronic, and they're not always completely obstructed, so they might take a little while to, become azotemic or uremic. So they might be losing weight or vocalizing from the pain. They may have signs of more chronic kidney dysfunction, such as PUPD or the weight loss or anemia. There may well be lower urinary tract signs, like if some of the stones have gotten down into the lower urinary tract and the bladder and caused cystitis or a UTI, then there may well be polarchyuria, dysuria, stranguria, etc.
Okay. Okay, so they can present like a fairly typical urinary
Yeah,
cat.
absolutely. Yeah, and I guess what you might smell a rat when you've got a painful cat that's straining to urinate, and you think, urethral obstruction, and then you feel an empty bladder.
Okay.
And then the plot thickens, and if you are lucky enough to have access to an ultrasound, then just checking the bladder and the kidneys might give you your answer. Or radiography is not without use. Calcium oxalate, thankfully, are mostly radio opaque, so it is worth shooting a radiograph to try and confirm your suspicions.
Okay, before we get to imaging, just a few questions about urinalysis that spring to mind. So if it's one kidney that's switched off because it's blocked, is that going to your SG, or does the other one just take over and concentrate?
It's a good question, but often you'll find that they can perfectly adequately concentrate the urine with the one kidney and not be azotemic, and it's not until that remaining kidney starts to dysfunction that they'll go through the progressive phases of nephron loss, which will be losing the ability to concentrate urine, become PEPD, and then eventually, when 75% of that kidney's nephrons are lost, they may become azotemic.
Okay, so if the other kidney is nice and healthy, then they're not necessarily in kidney failure.
Yeah, exactly. In humans, they can easily assess GFRs and determine which kidneys are working, but in vet, we can't really do that. So it's pretty hard for us to assess what's going on in the second kidney. It's not until that one's obstructed and failing that they're going to develop the signs of renal failure.
So are they mostly azotemic? Because the same logic can go there. Can that other kidney function well enough to prevent azotemia?
Yes, yeah. So about 15% of cases are bilateral on obstruction, but sometimes you can pick up a unilateral obstruction and the other kidney's fine. So in which case they may not be azotemic, but it's only a small amount of cases.
Okay.
And they may just present as being really painful, and it's not until imaging that you can detect them, and they may not be azotemic.
Okay, cool. And other stuff on urinalysis? Like are they hematuric, or what else would you see?
So depends, I suppose, on the degree of lower urinary tract urolithiasis, and sometimes you can have a nephrolith or a ureteral sitting up in the upper urinary tract, not even causing an infection yet. Sometimes you might have a raging pyelonephritis and a UTI. So you might find neutrophils, you might find bacteria, you may well find calcium oxalate urolith. To complicate factors, if you've got secondary infections, you might find struvite crystals developing as well once the pH changes, but let's not get too complicated.
Okay, cool. So that becomes very common. So you've got a calcium oxalate. You could have a calcium oxalate crystal stuck in the ureter.
Exactly,
Being out struvite.
Well, you've probably got a raging UTI and pyelonephritis by the time you've got struvite. So, but yeah, you may well find stones in the bladder and UTIs and oxalate crystalluria on urinalysis.
Okay. And then you said right in the beginning, when they present, they'll often present with a pyrexia. Is that because of secondary infection?
Probably, yeah. I guess if they're acutely painful enough, they might have a mild pyrexia, but if they've got decent pyrexia of 40 plus, that's usually going to indicate at least a UTI or maybe pyelonephritis.
So I think this is, if I've missed them, it's probably there where I go, yep, I've got a pyelonephritis, job done, sort them out, treat them.
Yeah.
And then they might go under the radar like that.
Potentially, yeah. And if you're lucky enough to sort out the infection, the ureteral obstruction, the stone might actually pass eventually.
Okay.
Only about 10% of them are thought to do that. But if you've got a really small stone, like say a millimetre diameter, it may eventually pass down the ureter.
Cool.
The ureter behaves a bit like the urethra in that if there's a stone, a rough, painful stone passing down, it spasms. So once that settles, then it might lead to passing of the stone. And I guess we can talk about medical therapy in a minute, but there are strategies we can do to try and support cats through ureteral obstructions that may avoid expensive interventions.
Cool. So it sounds like diagnosing it's kind of come down to scan.
Yeah, gold standard. Yeah. So I think if you've got clinical suspicion, signament's important. The breeds we talked about, it's usually middle. I guess another clue is that often kind of middle-aged cats. So
Okay.
kind of 5 to 8 is a typical age. One study reported the median age of 8, whereas a lot of our chronic kidney disease cats or acutely decompensated chronic kidney cats are geriatrics, 12 or 13.
Mm,
On average. So if you've got a kind of young cat in otherwise pretty good body condition, that might be a clue that you've got AKI, or acute kidney injury, secondary to ureteral obstruction.
cool.
And if the astute clinician sees that and sees an azotemia and can even shoot a radiograph, then maybe a ureteral obstruction should be on the radar.
Awesome. And then what do you see on a scan? That you are hopefully going to see the stone, but and I presume you're going to see some this dilation of the renal pelvis and the
Yeah, so I guess for a novice ultrasonographer, really subtle renal pelvic dilations are tricky, and they can usually the renal pelvis is collapsed. You usually don't see anything. If a patient's on fluids or if they're PUPD, if they're diuresing, you might get them distended to 2 or 3 millimeters. Pyelonephritis, the fluid might be distended to that or even 4 or 5 millimeters. And the fluid may become more echogenic as opposed to pretty normal urine, which is anechoic or dark.
Yep.
So that may mean you've got some pus going on there. And I think there's no doubt that if you're above 8 to 10 millimeters and certainly 13 millimeters, 100% the ureter is obstructed. 8 to 10 millimeters, it's pretty certainly obstructed. And I guess between 4 and 5 and 8 millimeters, then that's tricky. But you certainly want to get your good longitudinal section of the kidney and just scan through to see what's going on in the renal pelvis. If you can turn the probe 90 degrees, you might get a transverse section of the pelvis. And what you might even see is a distended ureter extending from the renal pelvis. And that can be distended a few millimeters across. You've got to remember a normal cat ureter is about 0.4 millimeters diameter, which is why stenting of them is so difficult, whereas humans are about 6 millimeters. So, human urologists have got it easy, whereas cats are tiny. And as soon as you try and intervene with the ureter gets really cranky and strictures and spasms. So it's a really tricky area. So so you might see the distended ureter. You might even be able to follow that most of the way to the bladder. It gets tricky because you've got colon and gas there a lot of the time. And you might even see a hyperechoic shadowing stone, either in the proximal ureter or further distal towards the trigone of the bladder.
Okay. How long does it take for the pelvis to start distending? So you obstruct on day one. When do you start seeing those changes? Do you know?
Yeah, that's a good question. I think within 48 hours, the renal pelvis will start distending, and they progressively distend, and also progressive nephron loss the longer they're obstructed as well. So if 2 weeks of obstruction, there's 80% nephron loss in the kidney. So the sooner you get in there and try and unobstruct it, then the happier the kidney's going to be.
Okay, so you have a bit of time. So it's not I diagnose one tonight at work and I have to go jump in there and do some sort of emergency.
Well, I guess the complication there is, and there may not be 100% obstructed. There might be a little bit of urine coming out, but you've got to be really careful that if they're essentially anuric and become hyperkalemic, it's an emergency. You need to decompress that area immediately.
Okay, so are we at treatment, or is there something we're missing?
I guess diagnosis is important. So we talked about the ultrasound and the azotemia, the important things. If you're lucky enough to have acid base, to see how bad the acidosis is, how bad the hyperkalemia is. Mate, in my experience, I haven't seen a lot of acute hyperkalemias like I used to see with ureteral obstructions, but the same principles, calcium gluconate to try and stabilise the heart, some insulin glucose to try and get the potassium down, but then that's only going to buy you time to try and get rid of the urine somehow.
Okay, so it's in terms of stabilization, it's going to be depending on what you see on your bloods, basically. You can see some electrolyte disturbances and bacteria. So initial medical therapy just to keep them stable is going to depend on your bloods. Is that right?
Yeah, so if you've got, particularly if you've got a neutrophilia, if you've got an active sediment, and can you hear my dog stomping
Yeah, I
around?
can. Yeah, I can see. He looks like an old dog. He walks like an old dog.
Got floorboards and nails. So yeah, if you've got a neutrophilia and an active sediment, then urine sample, even from the bladder, can be very helpful to try and diagnose a UTI, because you may well want to introduce antibiotics, analgesia, antiemetics. IV fluid support may be necessary if they're dehydrated. However, like any acute kidney injury, you've got to be really careful of volume overload. A lot of these cats present volume overloaded, which can be detrimental to return of kidney function. So we'll do whatever you can to try and monitor the urine output. If you've got some urine output, then you could even try some fluid and mannitol to try and diurese the stone out, particularly if you've got an idea that there's a small stone and it's in the distal ureter. That might help it pass. However, if you have got access to a referral centre who can sort out the renal pelvis with a sub or a ureteral bypass, then that would be the ideal management. But it's pretty expensive stuff. We're talking 12 to 15,000 for a sub in one kidney, up to 20,000 for a couple of kidneys. So it's huge money.
So what's a sub? Talk me through it. What do you do?
So a sub is it's a device developed by some vets in New York, Chick and Allison, who worked with Norfolk Vet to develop this subcutaneous ureteral bypass. Norfolk Vet have got a really good website. There's YouTube videos on them, but basically it's an artificial ureter. So there's a nephrostomy tube going into the renal pelvis. There's a little subcutaneous port sitting under the skin where you connect the nephrostomy tube, and in the other end is a cystostomy tube. So it essentially drains the urine from the distended renal pelvis via the port and then into the nephrostomy tube and hence into the bladder.
Wow.
So they're pretty cool little things. I'll make sure I get some information and some pictures for you for the show notes.
Cool.
And we've put a hell of a lot in. Some centres in the US and Europe and Australia have put in hundreds of them with great results.
Is that a surgical thing?
If you've got the luxury of fluoroscopy putting it in, then it's brilliant to actually see in real time the placement of the device. But probably the trickiest part is placing the nephrostomy tube, which does need surgery. Yeah, so you've got to go into the abdomen, and in the early days, people were using ultrasound guidance to place the nephrostomy tube in the kidney and then surgically connecting that to the sub and to the cystostomy tube. So you definitely need to get some surgeons involved, but certainly needs some medical and imaging input to do it as successfully as possible.
And is that permanent then? Like, do they have that?
Yeah. Yes. Look, there's complications, but it's about an 80% success rate in most studies and in my experience. And they can last for up to 3 years. I think the latest study had, median 3 years. Sometimes they need to be replaced. The main complications are infection, which is usually an issue if there's an already infection there. I think the figures are about 8 to 10% of them get chronic UTIs. And of course, being a prosthesis, they develop a biofilm, which makes them a real bugger to treat these chronic infections.
Okay.
The other complication is because these cats are stone formers, they can mineralize into the device and obstruct. So there's techniques these days to manage them with a solution called tetra-EDTA, which sort of breaks down the calcium oxalate stones and tries and prevents mineralization and can also help with the infections. But if they're managed properly, then we've got a number of cats that have had them in for 3 years or more, and some within both kidneys. Sometimes you find by the time the sub obstructs, the natural ureter becomes patent again. That's the best case scenario. And we didn't actually talk a lot about the differentials. So we can have strictures, we can have neoplasia, usually at the level of the trigone. We can also just get DSBs, or dried solidified blood clots, forming, and sometimes in combination with a stone. The other anatomical abnormality some cats get are a circumcaval ureter, where the ureter actually goes dorsal to the caudal vena cava.
Wow.
And that kind of causes a kink in the ureter and predisposes it to obstruction and stricture.
Okay, so it's not it's a predisposition, but they won't necessarily present as kittens. They could
Yeah,
get to
exactly.
adulthood
Yeah,
and then come in later.
yeah, it's sort of a recipe for disaster if you've got the circumcaval ureter and then you get a stone, because it's going to have a real problem getting around that corner.
I want to go back to the little blood clots. What are they?
Mm.
So the blood clots formed in the kidney.
Yeah, so in the kidney, either secondary to trauma or a nephrolith, something like that, and they pass down the ureter and form a clot, which then dries and then cause an obstruction to the ureter.
Will they resolve? Like
No, probably
they don't?
not. So you'd think that they'd be a lot more harmless than a stone, but they in fact cause as bad an obstruction as a stone. So they need some kind of bypass. Yeah, not saying subs are the only way. A few facilities, I know Davis in the States prefers doing stents in the feline ureters, but very fiddly and tricky, and I think you definitely need a specialist surgeon, and I think the results aren't quite as good as the subs.
So is the sub pretty much the domain of specialists? Like it's not something that you could, if somebody's keen to learn in GP
I think if
lab.
you're a very keen surgeon that's got a high caseload and throughput and sees a few of these, does some training, the AMC in New York where Chick Weiss and Alison Brandt work, they do training courses on these subs and other urological procedures. In general, it is a surgical thing, and you probably need to do a bit of training and work with some specialists, but I think if you can do that and get some practice doing it with getting the high case numbers, then I think a handy surgeon would be able to achieve it.
And what about zapping them with lasers or sound, whatever? I know in humans they try and break down the crystals.
Yeah, but that's certainly the treatment of choice in humans, and probably is being done in some university or research institutions in the States. I'm not sure if anyone's using laser for nephroliths or ureteroliths in Australia, but that may change in the future as people get more training and experience. So, but you're not really a viable option at this stage. So what I did want to go back on is and very understandably, if a sub or referral is not an option, so you can try medical management. As I said, about 10% of them may respond.
Okay.
As I said, very careful with fluids. Definitely need to have them on analgesia. I guess ideally a 24-hour facility with a fentanyl CRI is my choice. I think even buprenorphine is probably not strong enough analgesia. You've got to be really careful with NSAIDs in these cats because of their kidney dysfunction. Mannitol, I think you need to be cautious of that, particularly if the stone's unlikely to pass. But there's some support for drugs called prazosin and amitriptyline as smooth muscle relaxants, trying to minimize the urethral spasm and consequently the pain, and maybe help pass the stone.
So the mannitol, is that you're trying to flush it through?
So that's an osmotic diuretic. So, I guess it's an aggressive way of trying to combat these and hope that you might pull enough fluid into the renal pelvis and through the ureters to try and flush the stone. Probably not something I'd recommend.
And okay, cool. You're not gonna. I was gonna say, why specifically mannitol and not furosemide or another diuretic?
Yeah, it's a good point. I think the mannitol as an osmotic diuretic tends to draw fluid without altering electrolytes. It's also a bit of an antioxidant, kind of helps minimize some of the subsequent renal damage that occurs with the obstruction. Okay,
but you say you avoid it, rather best avoid it.
Yeah, I mean, I think unless it's pass, I guess sadly pass or die for the patient, then I would probably be avoiding it. And particularly if referral's an option, I'd try and give it a miss. And I tend to stick to just analgesia and prazosin and cautious IV fluids. A one-off dose of dexamethasone, may not do any harm, just to settle down some inflammation in the area. And some of these guys, need regular checking with the ultrasound to see if things are changing, bloods, and it may take up to a week to pass, by which time, I think you've already spent a hell of a lot of money. So if there is option for, decompression or referral, then that would be preferable.
Okay. And a lot of, sounds like a fair amount of prayer and good
Yeah,
good thoughts.
absolutely. Yeah, I've had a few come good, but yeah, I think you've got to, sadly, prepare the owners that have got sometimes a relatively young cat, prepare them that there may be a bad outcome.
So why can't you cut the kidney out? Is it because they'd like you to throw one on the other side?
Yeah, that's a good question, and yeah, that may well be a salvage procedure in some cases. And yeah, you hit the nail on the head there. The big problem is you've got to be really sure that the other kidney's working before you remove, and you'd have to do a nephroureterotomy, which is a relatively challenging procedure for a lot of vets.
Yep.
I wouldn't be game, for example, but you might.
No.
But yeah, you want to make sure there's no nephrolith or ureterolith or dysfunction in the other kidney. So, and even if you do, put a sub device in, if you can get them into both kidneys, you sort of never know how much function you're going to get even out of a kidney that looks hopeless and shut down. Sometimes you can save some residual nephron function. So a nephroureterectomy may be an option, but you just want to be really careful that the other kidney's happy before you do that.
Yeah, and I'm just trying to think, because you said right at the beginning that sometimes you find them incidentally with a shrunken little kidney, but
exactly.
Ethically, that's probably, you don't want to just say, well, sorry cat, I can't refer you, you're going to have to get over this, and we wait for that kidney to die off. That's not an ethical option, really, is it? Because of pain.
Yeah, so you need to have the conversation with the owner that you're going to try everything to try and save them and manage to keep the cat comfortable on medical therapy while hoping that the stone would pass. But it's not to say that small kidney is completely dysfunctional, but
Gotcha.
It's a big surgery to pull that obstructed kidney out and have a cat with stage 4 chronic kidney disease and one kidney. So I don't think it's the right thing to do.
No, absolutely. Is that it? Have we covered everything, or is there more? Is there anything we're missing?
Well, I guess we've talked about most of the complications and things with the sub devices, and they do need regular checkups for the flushing with this tetra EDTA solution. And even then, you can still get some mineralisation or infections forming. Sometimes the tubes pull out, sometimes they kink. If they're not placed correctly, sometimes they can leak a little bit. And I certainly had one very committed owner that would, we replaced the sub and we just couldn't get rid of the pyelonephritis, and we tried for I think 12 months to make this cat happy, and it had pretty much urinary tract signs the whole time, and we were very scared of removing the other kidney, and then we eventually removed the sub and that kidney, and now the cat's $1 million.
Oh, really?
That was that was about 2 years ago. So that was a success story, but we were very, very nervous about pulling the kidney out for a while. So.
Jeez, that's if you say regular checkups to have it flushed, to that, how regular is regular? How often is it going to the clinic?
Yeah, so we ideally get them out of hospital as soon as possible. At the AMC in New York, they get them out the next day. They routinely put a esophagostomy tube in to manage feeding and hydration and medications. We tend to have them in for 2 or 3 days post-op, and you sometimes see a dramatic reduction in the azotemia. Sometimes at 12 or 1500 creatinine, and they halve overnight, and
wow,
it's happy days, and the cats start eating and they're purring, whereas they were swearing and trying to kill you a day ago. So we tend to flush them at discharge and have them back in a week, a month, and 3 months for a flush.
So it's not like a weekly thing where they go to the clinic. Okay.
Yeah. And it sort of depends on the degree of residual kidney damage you've got, like any other CKD cat. But generally, we want to minimise their time in the hospital for flushes. And some of them, once we do them at 3 months, we don't see them for another 6 or 12 months. But it's a bit individual after that.
Yeah. Okay. Have we covered it all?
I think so, yeah. So, look, I was really keen to, kind of raise the profiles of ureteral stone. They're sort of a minority group when it comes to acute kidney injury. So just wanted to make more vets aware of it and aware of the options for management.
Yeah, I love it. It's great to have something on the radar that again, I don't look for them really. So it's good. Thank you. I think that's going to be useful.
And I guess also for ureteral or lower urinary tract obstructions, I really like to get the ultrasound on the bladder to see what the bladder's doing. A lot of vets are probably doing that already to see how many stones are in there. And, also a good idea to check the kidneys and just make sure that the upper urinary tract is clear as well.
That's maybe one of the key things, because we have more and more ultrasound in GP practice, and as GP vets fully capable of looking at the urinary tract. So maybe is the lesson that if you have urinary tract disease and cats, we go scan them if they're up for it.
Yeah, and if you can do a cheap price for a urinary ultrasound, and the more that vets scan kidneys and bladders, the more they're going to get used to normals. And once you see one of these bad ones, you'll never forget what they look like.
Yeah. Okay, cool. Thanks, Dave. That's awesome.
Okay, no worries. See you next time.
Before you head off, here's Dave to tell us about 2 very exciting conferences that he's putting on for Australian and New Zealand vets. I can't freaking wait for these. You've got 2 trips coming up, cancelled in 2020, back on the cards for 2021. Thank goodness, after a long and desperate break from traveling.
Yeah, really looking forward to kicking off Vets on Tour this year. We've got 2 great conferences lined up, both sides of the Tasman bubble, but hopefully we can travel to New Zealand, us Aussies. So there's an event in Thredbo for the first time at the beginning of August, and we've got some world-class speakers, including Rachel Corman speaking on feline medicine, and Dr. Alan Lai on surgery, and Keely Wilson on anaesthesia and analgesia. So I'm really looking forward to that.
Get Keely on the podcast.
Oh, you did you? Okay. So your listeners will be aware of how amazing she is, and full of practical advice and help. And so I get to work with her, and she's revolutionised our pre-med and sedation protocol and anaesthesia department. So she's awesome.
So have you got specific topics, or is that to be confirmed yet?
Yeah, just working on the lecture program now, but we've got a wide variety of topics that are going to be super useful to practitioners so they can implement them back in their practice the very next week.
Awesome. And but let's be honest, is it about the education, or is it about the skiing, Dave?
Well, look, it's world-class education, and happens to be in some pretty epic ski resorts. So we have a great day skiing and then get to sit back and learn in the evening with a great crowd of people.
The Vet Vault's all about creating a balanced life in vet. So to me, it just fits perfectly.
This is a very well-balanced conference, and I implore anyone to give it a try.
Give us the dates again, please, Dave.
Yeah, so I got Thredbo in the first week of August the 1st to the 6th, and Wanaka, I thought we'd better have a couple of weeks between events. So Wanaka's on the 22nd to the 27th of August at Edgewater, where we've been travelling to since 2005. So brilliant venue, one of the most picturesque hotels on the lakes with views of the mountains that you'll ever see.
Are they, just in case I wanted to do 2 conferences this year, are it different topics, different contents, or is it going to be?
Yeah, so we've got some local talent speaking in New Zealand, so that we won't have the awkward situation of speakers not being able to fly in. So we've got a couple of surgeons, Dr. Warwick Bruce and Helen Milner, who are well known to our Kiwi audience, and a few others based in Auckland, Dr. Sarah Hill and Jessica Romine. Apologies if that name's not pronounced right, but some medical talks and some diagnostic imaging to round it off with Carolyn Ivers. So a good 5-day mix of 5 different speakers, and I'm really looking forward to hopefully getting there and listening to what they've got to say after an epic day skiing.